When I was diagnosed, it was invasive ductal carcinoma, right breast, 9 o'clock. Came in to see you in your office and found out that, through diagnostics and through examination, that I was a good candidate. And you were pretty amazing throughout the process. I have vivid memories of the actual cryoablation and the margins surrounding the mass, and you were able to find a satellite nodule or tumor, and you were able to ablate that, which I remember our long discussion about how with typical other kinds of procedures, something that small could have been easily missed.
Right.
And that was really such a great confirmation that I had made the right decision to come and have you do the procedure, and your team was fantastic in support of all of it.
Thank you. Yeah, I appreciate it. Yeah, that was 2011, is that right?
I was diagnosed just in February of 2012.
Okay.
So it's been 13 years, a little better than 13 years now. And life has been great since then.
Okay.
Having no reoccurrence, thank God.
Yes.
And it was really amazing because when I had got my Oncotype score, it was the highest Oncotype score that, Dwight, my advising physician, oncologist, said he had, in 26 years that he was practicing, never had he seen an Oncotype score that high. So it was pretty scary, and having that option, and, was really, for me, it was life-saving. For me, it was a godsend. You were an absolute godsend.
I appreciate it. Yeah, our goal is, try to be able to treat cancer patients and leave them intact. That's the thing, is that, so many patients see, and they have surgeries, mastectomies, stuff like that. And that's a lifelong reminder. And, it's just, we want to be able to treat cancer patients away and leave them the same as they were before, or as close to it as possible, where, they don't have any major, things, and they can just forget about cancer. And our future goal, we're really trying to get at, and we just have to do the studies on this, which hopefully we can get done, is that, patients, when they're first diagnosed, you don't even biopsy them. You just take them right. You treat them, biopsy them all at the same time, and that would be the treatment. And that's how we hope to do it. It's just going to take some studies to prove that is the way to go, and but we'll get there eventually, and so that hopefully we can save women from having to go through these surgeries. And then, of course, all patients of cancer actually want to basically eliminate the need for surgery. And in the future, we'll look back and say, yeah, we never should have operated on these patients in the first place. But the technology wasn't there. A lot of stuff wasn't there. And now it's all coming together. And so, things are changing quickly, and it's just getting the system to accept it.
Yeah.
But patients like you are, an inspiration, because, you've done it, you've been through it, and here to be able to talk about it, and that lets people know that it is possible, and, it can be possible for others.
Yeah. I feel really blessed. I've had many friends that have gone the more traditional route, and it's often very difficult. I have sat across tables from women who had, double mastectomies, and feeling so incredibly blessed that I knew about this, and in some capacity, I fight the guilt, because I got something that not everyone knows about, and that's the challenge, right? That's getting the word out there that there are other ways to approach breast cancer and cancer treatment in general. I think that's really the biggest disadvantage that women have, is just the lack of understanding what is an option.
Yeah, the system has this way of treating people, and everybody assumes that that's the best, and so a lot of people don't do any research on it. They just go and do whatever they're told, and I think that's it's important. The patient needs to research things themselves and look and see what makes sense. And there's still a lot of patients. I mean, we have all the time with patients where we present, they know our concept, and they're like, oh, they're still going to go the other way. And it's their choice. It
is their choice, and that's what I try to remember, because really, it is such a personal choice when you get a diagnosis, and there will be people that have peace of mind. But I remember when these options were laid out to me, and Dwight said, there's this traditional option, and there's, and then there's this second option that's kind of a combination. And there's this third option over here. And he kind of shared with me your procedure and how that would look. And I said to him, if it were Jill, his wife, if it were Jill, what would you want her to do if it was his wife? And he said, I do option.
Yeah.
The third option, no question.
Yeah.
And I was leaning that way anyway, and that was just the little push that I needed. But when you get that diagnosis and you're listening to a doctor saying, this is what you need to do, and that it can be a life or death decision, you tend to want to go in that that direction with whatever the doctor says to you. But so you can't blame anybody for the choice they make. You just have to hope that in time, procedures like what I had will be out there in public knowledge and in the mainstream where that can be a viable option for any woman.
Yeah. I think obviously you were fortunate to know Dr. Dwight McKee, because he's very progressive and intelligent doctor, oncologist who just wants to do best for the patients. And that's he's a great person. He's great person, great friend, and always believed in our stuff, and believed in it when told Dwight, like, you believed in it when nobody believed in it. Nobody, there were just there are very few doctors, a couple of people like Dwight, but that they championed our work, and it was them that a lot of times kept me going too, because I think if nobody believed in me, it would have been a lot harder. So it was, to have just a few people was nice. And so that's what I tell Dwight. I'm like, I always, will be thankful for him. And so yeah, but that's fortunate. Yeah. Hopefully, now more and more people will all get access to this, and, it's coming around. It's just, so much slower than we would hope, but we'll get there eventually. Yeah.
Wow. You've always kind of had that pioneer mentality, and that's what it takes for change. Someone that's willing to step outside and look at things in a little different way and challenge the system and challenge the traditional approach. And I'm just very fortunate that I received benefit of that.
I appreciate it. Yeah, I like doing the stuff that other people don't do.
Yeah, me too, actually.
Right. I think it's just more rewarding, to do something that's new and unique. So yeah, well, good. Well, I appreciate you talking with me today, and good going through your story, and yeah, obviously got a lot of good stuff going on, and I'm sure I'll talk to you again sometime in the future. Hopefully not for cancer, but
I'm believing that won't be an issue for again.
Yeah, there is they get an immune response. They're like vaccinated against the cancer.
Yeah, Dwight, I spoke to him maybe a week ago. Actually, I think I spoke to him right before he said he was going to talk to you. And he So did you tell him about the itching? Did you hear that story?
Maybe I think I remember a little bit, but yeah, you might remind me. Yeah.
So it was really interesting because, there was the fatty necrosis for quite some time, and it was fairly large.
Yeah.
And then as the body was breaking it down, I would get itching. And at certain times, hormone changes and things like that, I would really feel it.
Okay.
And it was just this, but it was, he determined, or he suggested that it was the body's way of really taking that and dealing with it. And like you just said, kind of created this immune response, or some kind of protection.
Yeah, it's like a vaccination, right? Because you had the dead, like you think of vaccine virus, and you put stuff that stimulate the immune to attack it, and you inject it, and this your killer, and the immune system to make this happen more happens, but it was more rare. You mainly got tumor killing, like if you surgically removed it. But the question of how much immune stimulation. But yeah, now today is completely different.
What has been in your experience with the ablations in the earlier years? What have you had many reoccurrences? Have you had
the cryo? And it depends. So there's a set of cryoablation where it's done on lesions that are 2 centimeters or less. Those recurrence rates are all really low. When you get to 3 to 4 centimeters, the recurrence rate is probably about 12 to 15%. It mirrors what you might see with lumpectomy. And then over 4 is a challenge, and it's different. There are ways you can approach it. We have techniques now that are good. Before, our techniques were not as good on that, and we would take those on. Your recurrence rates were far higher, 30-40% at least. But now we have like a different technique where some of these tumors are bigger. We go in first and we ablate partially with pulse field, and we try to stimulate the immune system, and then we get to shrink, and then we come in and we can do a definitive ablation, a cryoablation, and get rid of it.
Yeah.
And so it's a staged procedure, and that works quite well, and it doesn't seem to have really high recurrence rate or anything. You're able to treat these bigger tumors. What we see is kind of newer techniques. I don't have the long-term follow-up to say for sure.
Yeah.
But looks promising. This is one direction that we're going, and trying to treat these patients, trying to ensure that we get that immune response. Because if you go in and just cryo alone, you could get immune response, but you may not, or you may get a minimal immune response. You add the immunotherapy, that's one thing. But the other thing is that if you do partial ablation, so you don't ablate the entire tumor first, that's more immune stimulating.
Yeah.
So you do that, get the immune system after it, then you can come behind and kill it all. Once you've got the immune system to see it, because you go right in and kill it all, then you don't get as much immune response.
Interesting.
So we've learned a lot. We've done all sorts of different work, and we paired a lot with doing animal studies, and that gave us a lot of data and a lot of things that we learned that we were able to apply to humans. And so it's definitely way more sophisticated than it used to be. Standard cryoablation, though, in lots of places now, it's coming around, and you're seeing that. So they're doing it. Unfortunately, they're a little bit behind, but they're doing it. So at least it's getting there.
I've read a little bit that they're doing it on organs that can't really be sectioned. But I haven't heard much on breast cancer in terms of cryoablation and thermal ablation on breast cancers.
They started giving some approvals for it. Until that rectifies, it's going to be challenging. People just aren't going to be able to get it because the cost. I don't know. Is it probably less than what you paid before. I think it kind of came down, but still not necessarily cheap. I mean, I think cryoablation is running, I don't know, 12,000 probably. A lot of it's the needle costs and just other supplies and things, and then the time that you're putting
what about the diagnostics? I know when I had it done, all of my diagnostics were through PET scans and imaging. So that's
still a lot of PET, a lot of MRI. I mean, there's definitely a lot we could do with MRIs alone. PET scans certainly have its role as well.
Yeah.
Usually we mix and match.
Yeah. That's what it was happening.
Yeah. Part of it, one, because PET scans have radiation, MRIs don't, so you can try to reduce radiation dose. The other, insurance, because like you try to do too much of one type of scan, the insurance doesn't want to pay. But if we mix it up on them, they're more likely to pay.
That makes sense.
So. Yeah, but there hasn't been, except for, which had kind of just come online when you had yours with 3D mammography, which is regular screening, and that's good for screening. But yeah, on our side, we're using, ultrasound, MRI, and PET CT. That's our main stuff. Yeah. So, good talking with you.
You too.
You have a good weekend and enjoy Florida, and yeah. Give your family the best, and yeah, hope his son-in-law. That's really good. Does he know what type of surgery he wants to do?
Yeah, he's interested in vascular surgery.
Okay.
Yeah. So.
Yeah. Tell him that he should definitely learn like the minimally invasive stuff, like the all the like the interventional type of things, because that's where a lot of that goes now. I mean, I think everybody, the vascular surgeons, cardiologists, that's the only thing is the cardiologists dominate that area. So if he probably should look into that.
Minimally invasive, as in
well, doing like more like catheters and not just surgeries. I mean, as an option that you could. I just tell him you might want to consider it.
Yeah.
So, at least where he could build them both.
He's in the thick of it. He's doing, multiple 24-hour shifts in a week, and he's all in.
It's brutal, but it's fun.
Yeah. So.
Well, good. Well, good talking to you. Take care, and I'll talk to you later.
You too, Jason. Okay. Thank you so much.
No problem.
Talk to you hopefully, and remember the clinical trials. If you need someone that.
Sure, yeah.
You are looking for that, I am. I'm really interested in helping.
I appreciate it
as well.
That'd be great. I appreciate it. Yeah. All right.
Okay.
All right. Take care. Thanks.
All right. You take care. Thank you. Bye.